Well, thank you again for that wonderful presentation. I'd now like to move us to our next panel, which will be led by my colleagues and friends to address statewide efforts for lung cancer screening, education, and navigation. We'll ask you to come on up. And I'll just say a word about each one of them because I think this really represents the best one of the best examples of how we're working collaboratively across Southern California. So Dr. Amy Cummings is a thoracic oncologist with expertise in lung cancer and other thoracic malignancies at UCLA. And she leads the Healthy Lungs California initiative under the banner of the California Lung Cancer Coalition and the University of California Lung Cancer Consortium. And then we also have Dr. Loretta Erhunmwunsee, who is Vice President and Chief Health Access and Community Enrichment Officer at City of Hope. And in this role, she leads the development and implementation of strategies that address health disparities. And then last but not least is Patrick Chen, who serves as Vice President of Population Health and Strategy and Innovation at MLK Community Healthcare. So I'm really pleased to turn the podium over to Dr. Cummings.
Well, thank you so much, Shanita. And really, I think the very first thing that I want to do is just applaud you for making this space for us, because this is where we find each other. And whereas 5 years ago, I think most people were excited to have equity and symposiums and make space for it, we're not seeing that as much today. And so the fact that you're here committed to this space, you're helping us all drive forward. And I just really want to applaud you and this effort here and the funders and the sponsors and the people that still care about this, because we care about this so very deeply. And as I take a look around the audience, I'm like, so many familiar faces. And this is where we found each other. We found each other at these equity symposiums. We found each other through these communications. And I have just made such great friends through this. And we're going to talk a lot about it. But let's kind of start with where we are. You know, how did we start this movement? Where are we statewide? Where are we going? I'll see if this, yep. Green button's pressing. This is always the first task, right? Can you get your slides to move? Is there another thing besides the green button I can use? There we go. All right, thank you. And so what we're looking at really is Healthy Lungs California. How did this get started? And there's a bit of history here, and so I figured, we'd go through this and then have a chance to talk about how we're all working together. And so last presentation was amazing. Thank you so much. I learned so much about navigation and why lung cancer, why California. A few more statistics for you. So yes, lung cancer is the second leading cause of cancer, but it kills more people than the top 5 other causes of cancer combined. And when you layer this in California, that has over 38 million people, we have the second highest number of new lung cancer cases. We're behind Florida by just a few hundred. And that's one of the states that has the lowest smoking. So what's going on here? And as another statistic for you, there is one person in California that dies every hour from this disease. This is a crisis, and this is one that we definitely need to address, and we're coming together to do it. Now, we certainly also know that lung cancer outcomes are unequal, and whether this is geographic, demographic, structural, environmental, or some combination of all of these, we know that there's a lot of ground that we can cover here. And we know that those that are most at risk are often the ones that have the hardest time accessing navigation and care and resources. And so in 2020, with Karen Kelly, who now is running IASLC, we created something called the University of California Consortium. We're really big into these movements, grouping people together, seeing what we can do. And in University of California, we do have 5 NCI designated comprehensive cancer centers that cover a lot of the population density areas in California. And as we got together, we decided that one of the biggest things we wanted to do as a lung cancer consortium was reduce the burden of lung cancer on Californians. And can we leverage all of the expertise that we have at our fingertips to help us do this? And as we started to plan about where do we get started with lung cancer, this was back with the State of the Lung Cancer report came out. And what you may see in that little red box on the very bottom, back in 2020, we saw California tied for last place in terms of screening those who are eligible at 1%. We were tied with Nevada. And when we take a look at cancer screening trends, you see lung cancer almost not even on the same graph as some of the other cancers that we screen for. And so this was certainly the lowest hanging fruit. This is the only mechanism that we know we can improve cancer-related mortality is by stage shifting and catching it early. And so we put together an initiative as the University of California Lung Cancer Consortium, looking at best practices, access, research, and supporting cessation. And we had Ashley Prosper, who's really involved in lung grads and radiology, leading this, along with David Cook, who was a thoracic surgeon up at UC Davis. Louise Godoy got involved at CDOC, and we came up with the plan that we were going to increase awareness internally, increase awareness externally, start to address our barriers, benchmark our efforts, and then keep reinventing this over time. And so we started this with UC Screen California. And so back in 2023, we brought Denny Aberly and lots of people together. Many of you were at that original conference to talk about lung cancer screening and where we can go. And so this got the attention of the UCOP president, who then listed lung cancer screening as a top priority for University of California campuses and really helped us drive this message forward. We also, giving a nod to navigation, decided that we were going to put in the public domain a website that would help people know whether or not they were eligible for lung cancer screening and make the commitment that if they were eligible for lung cancer screening, that we would help them find screening, no matter if it was with UC or any other healthcare institution. And we were going to do that within 12 weeks. That was our guarantee to people. And by using this website, we started to gather some information about what patients looked like. They spoke many languages. We knew that a little less than 1 out of 5 was actually eligible for screening when they did this sort of survey. It took, again, less than 2 minutes to complete. But what we found is that where people were falling off was in calculating their PAC year history. So we knew that that question was one that we had to iterate on and fix. And so then we also made sure that it was easy to use and that people thought it was worthwhile. So we got some metrics to help us get started. And then as we started to take a look at what happened internally, our goal was to increase sort of coverage across the UCs by 20% by 2025. And you can see here that our different sites had different success rates in terms of the eligibility. Now, with data, my PhD is in bioengineering, so I know the devil in the details. The devil is data, but we can use it and we can fix it and we can work with it. Just by making a few tweaks to data, we were able to increase our screening to that 20% benchmark in just a year. So, and this was looking at a few things. One, we were coding for people who actually refused lung cancer screening. We pulled in a separate discrete code to help us capture that. And we more appropriately defined our primary care population. So again, every institution has to come up with their definition of how they're benchmarking this. This is how we came up with ours. And what we found is that over time, our new screens were sort of dropping. So whereas before most new screenings, like the big entry into a program was around 50%, that was going down over time and our follow-ups were increasing. And that's sort of the most important part because you don't necessarily want to diagnose lung cancer on your first screen. You want to get it on the one after that because that's how you stage shift. You don't want to find a 3A when you first get started. You want to stage 1A. And that's in the follow-ups. So then we had some metrics to start to work with. And so we had our task force, we had our dashboard, we had our website. But we weren't enough at UC. We only see less than 20% of the lung cancer cases in California. This wasn't something that we could do alone. And so this is where all of us come together. And so we started something called the Los Angeles County Lung Cancer Screening Coalition. Wanted to make sure that we separated our consortium and coalition, although we still get them mixed up sometimes. So the very first time that we had a dinner together in 2023, we asked that question and said, can we work across institutions? Is this something we can do? The answer in 2023 was, no, I don't think we can do it. But we didn't stop. And here we have all of these partners who believed in this enough to say, I'm going to carve some time out of my busy schedule. I can get paid, $1,000 to $2,000 an hour just for doing what I do, but I'm going to donate this time to this coalition and see what we can do together. So we started conversations. We started to figure out what was happening with our FQHCs, what was happening at the county level, and we found out so much important information to help us drive forward. What were the barriers? Where were we falling down? And then what could we do to start to do this better? And so, again, we came together with the mission and the vision, and not unlike what we did with the consortium, we wanted to focus on lung cancer screening and disparities, because this we wanted to particularly call out, because if you impact disparities in California, you are saving thousands of people's lives. And that is tremendously impactful. You can reinvigorate communities, reinvigorate families. And so that's what we set out to do. And we came out with our strategic plan. We wanted to look at awareness and education, have campaigns there. We wanted to unite our voices so we can advocate for things that actually made a difference in terms of policy levels. We wanted to work on our pathways to care. How could we, at sort of these major hospitals and institutions that have access to every resource we can want, how can we get that for our FQHC partners? How can we help our county patients get the same thing? And then how are we going to work together? How are we going to benchmark? How are we going to use our data? Very much to all the points in the talk before. And so really what we're looking to do now is partner even broader and bigger in the screening landscape. If we can do it in California, can we do it in Hawaii? Can we do it in other states that have very fragmented care? And so with all of us working together, we kicked off the Healthy Lungs California campaign. And what this campaign is, it's basically access to resources. So if you want items, if you're doing a lung cancer screening education event or awareness event, and you want t-shirts or mugs or pens or anything like that with access to our website, you can have it. All you need to do is ask. We'll provide it to you. And to give everybody the access, give everybody the resources so we can help you keep stepping up and leveling up. And so in 2024, this is when we kicked off Healthy Lungs, mostly as a Los Angeles coalition. And we had 26 events in 60 days with over 30 partnering groups. We got $100,000 back in the community and over 500 people educated in the places that needed that education the most. So you can see some pictures of where we were. We were mostly focusing on healthcare deserts in Los Angeles County. So Taste of Soul, you can see patients there. Black Men's Wellness Day. We worked with ALSI to help volunteer at our organization and groups. We leveraged our partnerships, South Central Prevention Coalition, Celebrate Life, St. Mark's Baptist, and then all of our partners started to take that education and information and continue to spread it with our support. And so far more information was shared, because the work of one person can become the work of 50, can become the work of 100, and before you know it, you have a whole community that knows what's up. And so here you can see at the end of 2024, all of the people and partners that we had engaged with this. It was absolutely incredible. And again, we're so thankful to our partners because we help elevate each other. None of us has time to reinvent the wheel. We have to do what we all do best and leverage the best of everyone to tackle this incredibly challenging problem. And so back in 2024, in 2023, I got a hard no. In 2024, everybody showed up. So we had a partnership dinner where we started to talk about what it's really going to take to move this forward. What are we going to do next? And again, the reason that we were able to do all of this is because of industry funding. It's because our industry partners saw what we wanted to do and bought into it and said, we hear you. We care just as much about saving lives for lung cancer. We're going to help you get there. So incredibly grateful to that. And with that, we were able to launch off our 501c3. So one of the main challenges when we were getting started on this work was sort of getting money and funding into the right place. All of our institutions are very siloed. Sometimes it's really hard to transfer funds We have very high reporting requirements. And now with this 501c3, we're able to do things that we had incredible difficulties doing before. And you can see an incredible team of people that have gotten together to start to talk about what is this going to look like? What should we be doing? How are we prioritizing things? How do we make sure that we don't leave anyone behind? Because this is not something that any one person can know. This is what teams come together to figure out. And again, as we start to think about the success in Los Angeles County and broadening that success, how do we get across California? Who do we know in Central California? If you guys have contacts, let us know. We're looking for that. And so, because again, when you have a lot of people who have put their mind to something and driving something forward, you can accomplish incredible things. And so we now have, whereas the UC Screen California was a UC-focused website, we now have a California website, healthylungsca.org, which is a place that is now plugged into the Ralph Lauren navigation system, with the commitment that anybody that needs lung cancer screening who goes to this website and asks for it gets navigated to a screen within 12 weeks. That is our commitment, that is our goal, that is what we're going to be doing. And again, thanks to sort of the joint effort of many, we're able to start to deliver on this promise of a healthier California with fewer lung cancer deaths. And again, we sort of kicked off our Healthy Lungs website with an article in the Sentinel. Tony Wofford made an incredible sort of perspective piece. And so if you have interest in that, please take a look. And again, you can feel free to refer anybody you need to that website or that article if they're interested in learning more. Now, we're going to talk more as a panel, and Shanita, we should probably have you come up and be on this panel too, all honesty. So as we move into this new future, what do we think is really going to move the needle for lung cancer screening? And this is controversial, but I'm here to say it first on behalf of California Lung Coalition and the work that we're going to be doing with Loretta and Patrick. We think we need to be screening beyond smoking. We think that figuring out high-risk smoking individuals, while they absolutely need lung cancer screening and we need to reinforce that navigation and get those patients in, that only solves part of the problem in California because there are far more people getting lung cancer in California that have never smoked and that our screening guidelines are going to miss. So how do we refine that? How do we capture those data? And so as of today, we're going to be putting out a call for letters of interest. It's basically our geospatial call that we're looking for the data. We're looking for how can we generate that foundational evidence where we can push beyond the smoking guidelines. What does that look like? How do we do it? And we need all of your help. So please take a look. Shanita is probably going to send this out later today. We wanted to coincide it with the Equity Symposium. And so really there are 5 things that we're looking for as we move this forward. What are the missed opportunities in lung cancer screening? Can we even know what those are? What can we do beyond zip code? Many of us have looked at zip code and it may not be enough by itself. How do we start to get more granular features teased out so we can understand structural and geographic risk? And then can we better understand incidental pulmonary nodules? We have a ton of those in California. They have their own screening that's set up, but how do we layer that into the work that we're already doing? And then is there a simplified or risk-adjusted screening model that can emerge from this? And so what we're doing, lung cancer screening is a huge problem already. And are we blowing it up a little bit? Yeah, we are, but it's because we need to. Because as we get more people educated and aware and understanding their true risk of lung cancer, we're going to catch more lung cancers early. We're going to save more lives. And that's what we're all in it for, really, at the end of the day. So with that, we're going to move on to our panel discussion. So just to give you a little bit of background about healthy lungs. All right, thank you. Okay. And so first question to both of you is, why did you say yes to this crazy idea?
Okay, well, I have to say, I think it was one of the best representations of what we've been seeing in South LA. I'm from MLK Community Healthcare, a safety net hospital in South LA, the last nonprofit hospital in the region. We were built for about 30,000 ER visits a year. The lack of access to primary care and specialty care in our region has led to us seeing 130,000 ER visits in a year. And so when Amy and team reached out and started sharing about, the root causes of this, the inequitable distributions of medical infrastructure and what they wanted to accomplish, I was game right away. Just walked straight into our CEO's office, said, I'm going to join this. It's going to be a part of this. I will volunteer as much time as necessary, and here I am. So.
Thanks, Patrick. Yeah, first of all, great question and great presentation. I think for me it was very simple, probably very similarly. Just as you said, Amy, we aren't gonna, no one institution, one individual, one specialty is gonna solve this problem, right? Like it really is gonna take all of us. And so the idea of coming together with like-minded individuals, where we bring together critical stakeholders is right? Like if we think about the ability to actually lower disparities, stand up equity, and save people's lives, that is going to take all of us. And so the idea of partnering across our region so that we can actually do that, I was game from day one.
Shanita, I'd love to know why you said yes.
I'll just echo some of the things that were said, but maybe I'll sit at my seat. So for me, I mean, it was also because I think, again, echoing everything that was said, but, there was a strong personal connection for me in addition to the need to work collaboratively across our region. So, I had two family members, had very different risk profiles. One was a non-smoker, one was a smoker. Exact same sort of trajectory. They were diagnosed at an advanced stage. Within 6 months, they were deceased. And that's very striking. And so it made me be personally committed to try to work to address that.
Yeah, no, absolutely. And just to echo everybody's points, I've been told not to do this maybe 100 to 1,000 times by just about everybody at my institution because it's hard to do this type of work. You can't boil an ocean. How are you going to prove success? It's not aligned with our academic model. Your time is your most valuable asset. Why are you wasting it when you could be in the lab, doing experiments and writing papers? And I think that one of the things, it's sort of none of us is sort of immune or separated from the context. So, family members, being in the community, seeing the disparities firsthand, knowing how hard it is for patients to get into my office to get that treatment and how scary that is. There are so many things that add up. And at the end of the day, I mean, I've never really been good at taking advice, but this was something that sort of laid out in front of me, and it just seemed like the right thing to do. And when you feel like you're working towards something that is actually going to help people, actually going to help your community, and you can demonstrate success, that I think was just so exciting. And then as we got sort of more people together, like again, this has just been such an incredible experience with all of the amazing people that I've met over these years in doing this type of work, just some of the best humans. And so again, I'm very fortunate and blessed that you all said yes, so thank you for doing that. But it's one thing to say yes to an idea, it's another thing to show up consistently over time. And that's really where the value comes in, sort of being on that sort of 12th call. How do you think that we have started to make progress, or do you think that we started to make progress working together?
Well, what you've laid out of what's happened over the last few years, I think really shares a good perspective as to how we got to where we are. And I think the biggest progress has been really uniting so many different health systems that are all going to play a key role. I think too often, I come from a background of geospatial intelligence and mergers and acquisitions, and so too often our health systems somehow competing. It's a very unusual dynamic that we see within the current healthcare system. And so for you to create a team together with such amazing humans, I think you've put it eloquently, we have not run into friction of what our North Star is. And I think being able to move together with a very consistent cadence, game to pool our resources, our thoughts, our brain power, I think it's really, I mean, it's been really quite beautiful, but, tangibly, what's really going to happen from all this is that there's going to be such clarity as to what the right move is going to be. Oftentimes, I think endeavors like this are going to require public and private partnerships. So for outside industry partners, I say outside, that really, we're all in the same industry, I guess, for academic medical centers, and then definitely legislators will have to be a part of this down the line, for us to gather and be able to collectively agree on what the problem is and what the solution is going to look like. I think the work that we have upcoming to provide that clarity of where there is genuine inequity for how medical infrastructure is laid out across Los Angeles County and the state of California, I think is going to put us so far forward over many other disease-focused endeavors, because we have so many talented people and health systems working together towards that same goal. So I think it really is not something you see often. So I'm just an honor to be a part of it.
Thank you. I totally agree. The truth is, has there been progress? Absolutely. I think first, just as was mentioned by Patrick, right, the breaking down of silos is critically important and is our way forward. And the fact that we've been able to come together already, that first step is a huge one. I think when you mentioned that we're incentivized actually to work separately, and when we're saying intentionally that we're going to go against that grain, I think that's huge. I think when we talk about specifically, sometimes, we'll all, have our part in something and not really be aware of what the other person's doing. And we can still have incremental benefit and gain. And there's nothing wrong with that. But when we can literally come together and say, okay, we are going to articulate what the problem is and align around that so that all of our forces can come against that together in a strategic manner, I think there's really very little that we can't do. I think, when you have UCLA, MLK, USC, City of Hope, Kaiser, all of our FQHC partners, Cedars, coming together, talking about the fact that we want to improve lung cancer screening with our county partners, there's no reason why it shouldn't get done. I think that's one very important progress. I think another is the articulation that, look, smoking is a problem. It is a huge and major driver of lung cancer, but there are other drivers that we really need to call out, and we really need to be creating strategy and intervention around, particularly around the lung cancer screening that might include non-smoking factors. I think, again, that even being able to articulate that and say that is going to be part of our North Star is a major progress. So again, very appreciative of the opportunity to be a part of that.
Yeah, and so you two, so in terms of the RFA that just got put out, the sort of foundation for that idea really came from the proposal that the two of you put together. Could you share with the team what you're going to be doing over the next year or so?
Well, we're really quite excited about it. And so in short, there is a huge part of the discussion around what the source of the problem is. And when we came together and started designing and thinking about how can we put together meaningful research that will help provide what is going to be a common operating picture. So make sure that everyone, in this room, I think we collectively agree quite often on a lot of things, probably restaurant choices as well. And you guys, I'm sure I'm going to meet a lot of you on a regular basis. You'll know me as a guy that really analyzes things from a spatial point of view. I have a mild obsession with maps. I can create maps of absolutely anything. And Loretta's background is absolutely phenomenal. And so when we sat down and started talking about it and understanding how, well, now we have so many of the providers united, there is a whole other part of the conversation for the total patient journey that we can't ignore, which is going to be how fragmented is that patient journey all the way up to the point when they're seeing clinicians like Loretta and Amy. And that fragmentation is heavily influenced by the payers. And when we started talking through how do we document this fragmentation of care, we started looking into then what a truly comprehensive assessment of this could look like. And of course, medical claims came to the conversation, social determinants. And so we started designing a study in which we can compile 10 years worth of medical claims for up to 20 million Californians, whether they have smoking status or not, to be able to put together this master patient journey, understand across this full continuum, where are they falling off? Where is our system failing them? Because if we're being quite honest, our current infrastructure for California, for LA County, realistically for the United States, isn't working for this population. And so with what we're seeing at MLK, with what we're seeing at City of Hope, we thought designing something that would put together a fully comprehensive view of the patient journey, layered in with the geospatial intelligence that we all know and love, maps upon maps, and started putting together a lens in which everyone, even people outside of this room, policymakers, funders, industry partners, can see what we see. And so what that's going to look like is a full documentation, geospatially, of course, of every medical infrastructure asset that is critical to lung cancer care, everything from screening to treatment, and everything after that as well, which navigation would be a massive part of. And we are going to start using that to be able to influence policy, to help shape our thinking, and to really, now we do have a North Star on what we want to accomplish, but it will help us provide a lot of clarity as to where these gaps currently sit at a structural level and what type of investments are necessary to be able to tangibly tackle this, because we can't do this alone. So happy to add on to that, but I think Loretta has a huge part of this.
Thank you, Patrick. So, I mean, to your point, one of the reasons we were really excited about this is that there is still an undue focus on individual patient barriers, right? And you know, as a thoracic surgeon, it was often what I heard was like, you know, it was a patient issue. There was a patient non-compliant. There was a problem with like the individual. And the truth is, what we really do understand is that upstream factors are critically key to how patients are going to show up and their ultimate outcomes. And so it was then very important for us to zoom out and understand that it isn't just transportation. It's not just that this one individual has or doesn't have a car, or has or doesn't have gas, right? Like there are upstream, bigger structural factors, social factors, environmental factors that we absolutely need to be able to understand, assess, and then include in our modeling and understanding of patient outcomes. And so there's going to be a lot of predictive modeling that we'll be doing as well, so that we can understand from the outset when a patient is met. But look, because of even your neighborhood and your social factors, you know, these things are influencing your outcomes. And so we need to understand those better so that we can help support your walk through this journey. And so for us, it was, I think we're finally getting to a place where we will be able to articulate how these factors come together so that we understand that, again, it's not just a patient issue that's driving an individual's poor outcome, but it is in fact societal. It is in fact structural, right? And so, and I think one of the things that we're most excited about is to really be able to paint this like clear picture, right, of where the gaps are, so that we as systems who do have a part to play in this will be able to create some infrastructure to better support individuals through their journey. And as Patrick said, like, we've got to be engaging with our payers. We've got to be engaging with our legislators, because again, this isn't these aren't individual issues. They're more structural. They're even policy related, right? And so when we can bring that all together in a way that is understandable, and that's part of the deliverable as well, it's like we want people to be able to understand that this isn't some theoretical, oh, it's just bad luck. No, it's like these are the gaps, and these are the places where we should and are responsible for intervening. So I think in about a year or so, we should be able to have some of those tangibles that we can then help with the intervention around.
Amazing. And just as a plug, we're starting a work group with sort of monthly meetings. So if this is interesting to you and you want to be a part of this, doors open, just let us know. And so I'm going to continue asking questions, but if any of you have questions, feel free to raise your hands for the panel. We have some great people up here. And I think, while we're looking for people who may have questions, the payers, that's sort of a big deal here. And that continues to be a sort of an area that we haven't been able to really sort of advocate effectively yet. Because what is the value of a life saved? We have a really hard time quantifying that. And so I think it looks like, did we have a question out there? Yeah, did you? Yeah. Oh, yeah. And so how do you think, what is the level of evidence that you think we're going to need to convince our payers?
I think one thing, and do we have any payers in the room? Because if we do, we should just ask them. But I do think that we are going to, have to articulate the cost savings, right? I've always said, and I think a lot of us understand, that there is a strong return on investment to doing things equitably. There is, if we can prevent and detect early, we save lives, we save the ability for people to continue to work and to contribute to society. But also, the truth is, caring for someone through advanced stage lung cancer is far more expensive than providing lung cancer screening. We could do that math easily all day, right? And so but I do think there's more granular details that we can give to our payers to say, look, there is benefit to doing this well, catching this early, and ensuring that people, that we are understanding the social drivers and barriers that might be getting in the way. There's cost savings there if we did this right. I think, I'm not as much into the literature around the cost savings around patient navigation and clinical nurse navigation, but I know they're significant, right? Because again, when you can efficiently get people to the best care, then we're going to be able to save money. And I think that is probably something that the payers would very much benefit in knowing more about.
Well, I think you've covered it quite well. And all I would add to this is that, through this work, we will be able to help simulate and demonstrate, how different it would look when a South LA Watts Compton patient, what it would have looked like if they lived somewhere else and if they had a different payer. We'll be able to say the cost savings. We'll be able to say the lives saved. There are universal statistics that are understood by everyone outside of healthcare as well. And for the most part, it's going to be dollars saved and lives saved. The incremental spectrum of how you communicate all of that, I think it will be up to the group for us to decide, what type of united voice we'd like to put together. But absolutely, through this work, we will be able to put through those universal statistics, lives saved, dollars saved. And I think, society can look a little weird sometimes in terms of how we agree upon things. But we do, at some point, have to make a decision, what is worth it? And everyone in this room knows absolutely that this is worth it. But there are definitions out there of what is deemed to be medical necessity. And I think through this work, we want to influence that. We want to move it in a direction that we think is more ethical, is better for society. And yes, there are lives saved and dollars saved, but this is the right thing to do. And not everything will come to fruition in a 12-month period per an actuarial model, right? I used to oversee health economics and actuary services for West Coast for Optum. And, sometimes these models don't quite put together the broader picture of what a lifetime value looks like. And I really do want for this work to help inform that and to help kind of broaden, people outside of this room, their understanding of what is worth it. And we really want to make a difference there.
Hello, there you go. My question was around, so you've brought together a lot of great partners, and I was curious, when you're talking about the journey, the chronic care, sort of, how are you bringing in the physicians and the chronic care networks to also tie it together too? Because, you just don't wake up and say, oh, I have cancer and then see you, right? It starts somewhere. And so how is that being sort of folded into all the work you're doing?
Yeah, and maybe I'll kind of jump because there are multiple layers to this. There is no one path. It's sort of the convergence of multiple paths to one point. And so part of what our Healthy Lungs is, it's sort of patient education, awareness events, but it's also provider education, making CME. So you can, all of our physicians need CME to maintain their licenses. Can we make some free CME that's interesting and entertaining about lung cancer screening? And so, because we need everybody, right now at UCLA, most of the people being referred to lung cancer screen are coming from pulmonologists, but we know that our primary care doctors are sort of the first line for so many, and maybe the only person. A lot of people don't know they have, sort of COPD or other lung problems until their primary care doctor picks up on it. And so I think that there are layers upon layers upon layers, and all of it's important, which is why we need to take everybody with us. We need everybody to do it together.
Other questions?
Hi, I had a question, and I wanted to say thank you to the speakers as well for talking about the social determinants of health when it comes to lung cancer, transportation barriers, policy, and all of these kind of geospatial factors. And when we talk about non-smoking lung cancer cases, obviously one of the big risk factors we think about is air pollution. And so I was curious if you all could speak to what the coalition is doing, if there is already engagement of policymakers or environmental health researchers to try to, it sounds like trying to come up with new guidelines to try to catch these patients where it's not easy for them to move out of a neighborhood where they're exposed to a lot of air pollution.
Yeah, no, I mean, that is sort of a very exciting. So one, we certainly have talked a lot with our environmental scientists because they all have maps. We have our transportation corridors. We know where the diesel trucks are running. We know where the ports are. We know the communities and neighborhoods around there. And I think that's one of the reasons that our zip codes sometimes fall down, because zip codes can be big, and when we're really looking at distance, it has to be sort of more specific and granular. Now, you can imagine that we're going to open a whole can of worms here because California, just housing prices, it may be surprising that some of the highest PM 2.5 areas, there are certainly some low-income neighborhoods there, but there also are some that aren't. And so I think we're just starting to understand how important lung health is in California. We're just starting to have the access to all of these data points, and where we are right now is really just doing the foundational evidence. Because when we think about what's going to be the optimal screening tactic, you get 10 of us in a room, we're going to debate this for an hour, and we're not going to end up anywhere. That's why we need these data to kind of help guide us. What do we see? Because it's not going to be just one thing. Is it sort of ancestry intersected with PM 2.5, intersected with germline risk? Like, there are so many variations of this that may be meaningful. And again, why we're trying to bring our best data scientists together. So we have our environmental scientists. They're with us. They have their maps that they're sharing with us. And that's one of the overlays we're going to have. But you're right, incredibly important. Fires, exposure to fire is incredibly important. There's a lot to unpack in California.
Just to add really quickly, I think that's an excellent question, and thank you for that comment. There's no question that air pollution, PM 2.5, nitrogen dioxide, and other pollutants are critically important factors that we've got to really wrap our arms around. We do a lot of work in that space, and I know you do as well, especially in this sort of geospatial context. And I think, there is a real need for us to understand its influence on biology, its influence on, the risk to other parts of our bodies. And what we're starting to understand now is, I think every day there's just new data that's coming around about the influence of PM 2.5, particularly on just sort of the damage to our lungs, and sort of pathogenesis to lung cancer. And so what I would say is that we are continuing to sort of engage in understanding that information better. But what we really need is like even better sort of analysis, right? So when we talk about the zip code, right, like we understand now zip code is the wrong answer, I would say, for that assessment, right? So we're doing work at block groups and census tracts, and you probably need to do even small, even more granular. There was a period of time where folks were literally doing home monitoring of the PM 2.5 and trying to understand, hey, look, do we need to be understanding this at the house level? And so that information is still unclear, but I think what I would hope for us more, even in this organization, is that we would really push this more, especially because, and I'm just going to say it here, there have been rollbacks of regulations around air pollution and around, what is allowed. And we know that it is marginalized communities that really will experience that pain and harm most. And so I do think it is very incumbent upon us to have this data and to be very clear to our legislators that the inequities, that the rollbacks and the rich people get to have really does cause harm to certain groups. And so I appreciate that question. And I just want to say that there's a real need and there's a lot going on within this coalition in that space as well. Do you want to add?
I'll be brief because I think we're at time. I think you bring up a phenomenal point, and you're right. People can't just move away, right? So we can communicate, we can document, and we can assess the genuine geographic risk associated with living in that area that can likely come from historic redlining and kind of a modern day redlining, if we're being honest. What I can say is that what we can do in through this coalition with the hospital partners, because we do have our medical record systems. What we do here at MLK is that we geocode every patient encounter, so everything is associated with an XY coordinate, so we can create these bespoke, tiny little Lego pieces at like 100-foot radiuses to document and basically associate any and all outcomes with that. Overlay any pollution data, overlay SES data. There is a lot that can be done, and if you have any suggestions that you would like for us to add into that, all ears. And so, but every patient encounter can be associated with the XY coordinates. So that type of granularity does exist, really mostly at the provider level for that type of flexibility, because claims only tells you so much. Claims weren't designed for equitable analyses; they were designed for financial billing. So absolutely, this is why we blend all these different data sets, and happy to chat more about that.
Yes, so my name is Alexander, and I was gonna ask related, I believe I also asked this question last year, or it was similar. So I believe that in these communities normally, and I'm speaking by myself, I'm a Latino, Puerto Rican student here at USC, and we tend to reach pharmacies before going to a hospital because looking for a more quick or free or cheap consultation of a healthcare provider that might tell us, yes, you should go and see a doctor, then you should go and see a pulmonologist, or like encourage us and educate us by letting us know that we have factors that should, that should put us in a spot for us to do a screening. So my question would be, do you believe that because of these factors, and unfortunately all the pharmacy deserts that are in South Central LA, so patient doesn't have quick or cheap access to a pharmacy, if these are factors that are holding patients into getting education and encouragement to follow up for a lung cancer screening? Because I know that we mentioned about the primary cares, sometimes they refer them to the pulmonologist, but I feel sometimes for these communities, they like to go more for the pharmacy because there is no cost. So if there's anything that the Alliance is working on to implement how pharmacies can play a role at the time of improving screening?
So the short answer is that you bring up a very important point. It's certainly something that we've discussed. What's the best route? Because there isn't going to be one route that works for every group and every cultural community. We have to figure out what works best for each sort of subset of what is the incredible makeup of California. And so you bring up a really good point that the pharmacy is sort of can be a home and is sort of primed for a project. You're absolutely right. Think about applying.
Okay, all right, I have volume. So my name is Siobhan Moore-Cage, and I was really excited to see South Central Prevention Coalition up there. That is who I work for. I am the family health ambassador for South Central Prevention Coalition. But one of the main things that I do there is I have wellness fairs all over, because we know that people, a lot of times they don't go to the doctor because they don't want to. Sometimes there's barriers, we know the social determinants of health. There's all these things. So I bring it to them. I have them all over SPA 6 and SPA 6 adjacent. But what I want to know, because Tony Wafer, he sends people, I have Ralph Lauren, Cancer Center, Yuvia and Mario, they come out. I had an AstraZeneca, that Air Mobile. They were actually doing a lung clinical trial on site at my last event. Do you guys have access to a mobile unit that can do lung screenings? Because I will take it everywhere.
I was like, Zool, where are we on that? Sorry, Zool, didn't mean to call you out. But no, you're absolutely right that the mobile unit is sort of on our sort of strategic plan as sort of a huge contributor. And if we have the data to back up where we should bring it and when, that's going to be great. So Zool, the mobile unit.
We're still raising money for it, but there's a vision to create one, and I'll talk a little bit about it in my presentation, but thank you for bringing it up, and it's essential, really. LA needs one. There isn't one on the West Coast of the United States, so this would be the first one. So let's work together to make it happen. Thank you.
Yeah, so thank you so much. And as you can see, this is a team effort. Everybody here is involved. So thank you so much for inviting us. And well, I think